For HER2 positive patients, we test at the beginning when they're first diagnosed in the stage 4 setting, and that occurs, the positivity rate's about 10 to 15% of gastroesophageal cancer. And in that setting, they would get chemotherapy plus trastuzumab. The standard TOGA study, which is now several years old, published in 2010, was the landmark study that compared chemotherapy with cisplatin and 5-FU or capecitabine, physician's choice, to trastuzumab with that regimen. And it was a positive study, and it became standard of care for those patients. Because FOLFOX chemotherapy, which is still fluoropyrimidine plus platinum, is a preferred regimen, it's considered better tolerated, less toxic than cisplatin versus oxaliplatin, many of us that treat this disease will replace the cisplatin with oxaliplatin and treat with FOLFOX plus trastuzumab. So that's a very standard approach to do in a HER2 positive patient. For HER2 positive patients in the second line setting, this is a difficult situation at the moment. There have been a number of studies that have assessed what to do at that point in patients in the second line setting after progression on first line fluoropyrimidine and platinum plus trastuzumab. Unfortunately, 2 large phase 3 studies have been negative, one assessing the utility of lapatinib in the second line setting, and one assessing the utility of TDM1 in the second line setting, compared to standard controls of paclitaxel or paclitaxel docetaxel in the latter study. Unfortunately, they were both negative. The issue there is that patients that were diagnosed as HER2 positive are considered HER2 positive throughout the course of their treatment through various lines of therapy. What we're now finding is that patients, if they repeat a biopsy at the time of starting second-line therapy, their biopsy no longer is HER2 amplified. That occurs in a range, depending on what studies you're being referenced to, from 30% up to even 70 or 80% of cases are evolving to become HER2 negative. So in the setting of assessing what to do in a HER2 positive patient in the second-line setting, the notion now to check to ensure that a patient is still HER2 positive, has retained HER2 amplification, those patients potentially could still benefit from continued anti-HER2 therapy. On the other hand, patients who are now HER2 negative, you can imagine, probably don't derive much benefit from anti-HER2 therapy, and in that setting, they should be treated with a standard second-line regimen like a paclitaxel or FOLFIRI plus ramucirumab.